let's go over the important board-centric points for congenital adrenal hyperplasia genetics. We need to know how to counsel patients on the genetics of 21-hydroxylase deficiency, explain frequencies of classic and non-classic alleles, and discuss risk assessment for offspring based on genetic carrier status. To understand this question, let's go through two scenarios and see what the outcomes are. First is this scenario. Scenario number one. The mother has non-classic 21-hydroxylase deficiency, and she has one classic allele and one non-classic allele. The father has one wild-type allele, normal, and one classic allele. He's a carrier. And we're going to go from left to right. In the first scenario, the child is a carrier because the child gets one affected gene and one normal gene, asymptomatic. Second option, if the child gets two affected genes, the child will have classic 21-hydroxylase deficiency, adrenal insufficiency, salt wasting, be very symptomatic. Third option, if the child gets a non-classic allele and a wild-type allele, asymptomatic. And then the fourth option on the very right, if the child gets one classic allele and one non-classic allele, they will have non-classic 21-hydroxylase deficiency, milder symptoms, hyperandrogenism, no adrenal insufficiency. Now, if you look at the outcomes, you'll see 25% chance of being affected with classic 21-hydroxylase deficiency, 50% chance for being a carrier, and 25% chance of having non-classic CAH. Now let's look at a second scenario. The mother has non-classic CAH, and she actually has two non-classic alleles, and the father is a carrier of non-classic allele. Let's look at the outcomes, and you can see there's a 50% chance for the child to get two non-classic alleles. In that case, they'll have non-classic CAH, and then there's a 50% chance for the child to be a carrier, being asymptomatic. Now, once we understand that, now we can look at the question and what they might ask us. First, we'll talk about the prevalence of CAH in the general population. Classic 21-hydroxylase deficiency is 1 in 16,000. Non-classic is 1 in 1,000. Now remember, this general population risk of 1 in 16,000, this applies to the general population, but not somebody with a family history. The question I'm discussing, it's a young childbearing woman, and she has documented non-classic CAH, and she wants to start a family. And they say, what are the risks of having an affected child? Now, we start off with this premise. Even without knowing the patient's genotype, we know that her child is at a higher than average risk for having an affected allele just based on family history alone. And we have to remember this. The carrier frequency of classic CAH alleles is approximately 2%. So the chance that the patient's partner is a carrier, it's 1 in 50, it's about 2%. Now remember, we talked about the two scenarios. When the mother has non-classic CAH, she could either be a carrier of a classic allele or have two non-classic CAH alleles. But let's assume the worst case scenario, just because they're not giving us genotyping in the question. If the mother has one classic allele and one non-classic allele, then remember our calculations. There was a 25% chance of the child having classic CAH. So 1 by 4. Now, remember, we said that the frequency of classic CAH alleles is approximately 2%, or it's 1 in 50. So Without any genotype testing, the probability that this couple will have a child affected with classic CAH is 1 in 50 multiplied by 1 in 4 is 1 in 200, which is 0.5%. The answer is 0.5%. So there you go. This is important for congenital adrenal hyperplasia because it's also mentioned in Endocrine Society guidelines, and these are some basic concepts we really need to know. Thank you.